London Bridge Sports Medicine Podcast.
Welcome to the LBSM podcast. Today we're joined by Dr. James Gratwicke, who is a leading neurologist and somebody who specialises in headaches and migraines. We'll be exploring what migraines really are, who they affect, and what some of the common misdiagnoses are, and also how modern medicine approaches treatment. So welcome, James. It's really nice to have you on the show. Thank you for giving up your time today.
Thank you, Lucy. Thanks for having me on.
No problem. So let's sort of get straight into it if we can. So for our listeners, try and just, if you could start by explaining what a migraine is and how it differs from a standard headache that people will kind of get on a more regular basis.
Well, that's a really great way to start. And actually, I'm going to flip that around and say what differs a standard headache from a migraine. So,
okay.
Migraine is actually a genetic condition, largely. So when the sperm meets the egg to make you, there are genes that will say you have a certain eye colour, a certain hair colour. And there are, as far as we know, several hundred genes that give you cumulatively your genetic liability to migraine, which is lifelong. So it's a genetic liability. And the point you make about a standard headache and a migraine, what that's coming back to is the fact that most people's perception of a migraine is what they've seen on television. So most people think of a migraine as kind of the Hollywoodized version of it. I've got a banging headache with stars and spots in front of my eyes. Now, yes, that does exist in migraine, but that only actually accounts for about 2% of migraines. Migraine symptoms are much, much broader than that. So to answer your question, I say to a lot of people who come and see me in clinic and say, they come in and they have that Hollywood version of migraine. And I say it's a migraine. And they say, oh, yes, I've seen that on TV. And I say to them, have you had a migraine before? And they say, no. I say, have you had a headache before? And they will say, oh, yes, I get normal headaches or standard headaches. And I say, it's not normal, ever, to have a headache.
Okay.
The point is, all headaches are migraines.
Okay.
So if you've ever had a kind of mild headache triggered by stress or dehydration or poor sleep, which just kind of been settled with a bit of paracetamol, ibuprofen, that was a migraine. It's just a very mild migraine. So the majority of migraines are actually very, very mild. And so the public perception is that migraine is only the really severe type, but actually most of it is extremely mild and most people don't even realise they've got.
No, I would never. I mean, I fortunately don't suffer from headaches very often at all, apart from sort of heavy nights after. But so I would never sort of think about that at all. I do know people who do suffer from quite sort of significant migraines. But like you say, I always sort of imagine that that's different and that you have to go and lie in a dark room for a few hours.
Yeah, so migraine is a little bit like an iceberg. That's the way I think about it. So about 2/3 of it is under the waves. That's everybody with their normal headaches who have minor headaches, and it's never enough to really be too debilitating, and they don't present to medical services, and they never know they've got migraine. And then above the waves, you've got that 1/3 who've either got much stronger migraine symptoms, as you've just described, or much more chronic symptoms. And they're the ones who present to medical services. And that's why we think of migraine as just a bit above the wave.
Okay. And what are the main symptoms or the most typical symptoms that people describe?
So the most typical symptoms of migraine, what I refer to as the core symptoms, they're the 5 main symptoms that make up the International Headache Classification criteria for the diagnosis of migraine. So they are a headache, and classically the migraine headache is side-locked. So it's usually focused more on either the left or right side of the head. And in most people, it's nearly always on the same side each time it occurs. Now, there is variability, and sometimes it can be over the whole head, sometimes it's more focused around the front. But yes, it's usually a lateralized headache, and it's associated with 4 things. Now, you don't necessarily have all of them, and you'll only get these when the headache is more intense, not if it's milder. But the 4 things are sensitivity to light, sensitivity to sound, sensitivity to movement, and nausea or vomiting, or the more minor version of that, which is lack of appetite.
Okay. And those are the symptoms that almost everybody will come to you in with some degree, presumably.
Yeah, so those core symptoms, everybody who's got migraine has got some of those core symptoms in some combination. And then they may also have what are called the aura symptoms of migraine coming and going on top of that.
Okay. And how, I mean, obviously you were saying that in terms of the general headache rather than the migraine, or what people perceive as a migraine, is it affects, headaches affect a lot of people, but in the general population, migraines are actually, the worst type of migraine are actually quite small, I imagine. Is that right?
Yeah, I mean, migraine is a very common condition. It's the most common condition neurologically worldwide. So you're right, the more severe migraines are much less common than mild migraines, but still, because it's a common condition, overall, there are a lot of people who do have quite
them.
debilitating migraine.
Yeah. And are there any specific groups of people who are more susceptible to these problems? Do you find that it's younger people, older people, women, men, or is it just a total mix?
So it's like I said, migraine is a genetic condition. So between different individuals, people have different kind of strengths of genetic liability to migraine on a spectrum. So it's not really so much to do with characteristics of a person or their age. It's overall how strong is their particular genetic liability to migraines versus somebody else's. However, there are factors that can, in the course of a person's life, influence how many migraines they get. And in particularly in women, there's a big hormonal influence, which will influence how many or how severe the migraines are at particular phases of their life relative to other times.
Yeah. And so with regards to some of those things, I guess the hormonal factor, is it a one particular hormone? Is it when you're kind of, I guess, from my point of view, I'm quite interested in kind of perimenopause and that period of time. Is that a time when women are more susceptible to getting migraines?
It is. And let me explain why briefly, because let's just delve quickly into what is a migraine. So give you a kind of frame for that.
Yeah.
So most people, just a bit of semantics here, most people think the word migraine means headache. It doesn't. It's just that headache is the most common symptom of a migraine. So what is a migraine? So the pathophysiology of migraine is quite complicated, but I tend to kind of slim it down to a kind of, if you like, a simplified version, which I think makes sense to most people, which kind of consolidates a lot of the academic work. The way to think about migraine is as follows. The brain is an electrical organ. Electricity flows around the brain in all of us all the time. And what a migraine is build-up of electrical irritability on the surface of the brain in an area no bigger than about a 2p piece.
Okay.
And that's what a migraine is. Migraines can basically cause symptoms in two ways. The core symptoms are caused by that electrical irritability, triggering release of a little chemical called calcitonin gene-related peptide, or CGRP, which irritates the lining of the brain, the meningeal lining, which surrounds the brain and the optic nerves. And it's irritation of that lining that gives those core symptoms. And then the other bit of migraine is that the brain is structured a bit like a computer. So different bits of the surface of the brain process different bits of information. And when that migraine is occurring on the surface, it can electrically interfere, scramble, if you like, the processing of the bit of brain underneath it, which will give rise to some visual perceptions or other sensory symptoms, which are the auras of migraine, which is one of the things that often worries people. So that's what a migraine in a nutshell kind of is. And the reason that hormones are in women have such a big part to play is that high levels of estrogen in the brain make the brain more electrically irritable.
Okay.
It's partly to do with how much estrogen, it's partly to do with the kind of how sustained a high level of estrogen is as well. So it's not just about how much, it's kind of about the patterning. This is why often a lot of women get migraines locked to their periods, because that's the point of highest estrogen concentration in the bloodstream, so the brain is most electrically irritable. And coming to the menopause, migraine control often significantly deteriorates in the perimenopausal state because of the amount of hormonal fluctuation that's going on, meaning that the brain becomes more electrically irritable due to lots of estrogen fluctuation.
That's quite interesting, because I was thinking, that might be quite good for people who are perimenopausal or menopausal, because there's often a drop in estrogen. But as you say, especially in perimenopause, it's up and down, isn't it? So I can see why that would be a cause or another irritant.
Your point, though, does hold that post-menopausal migraines tend to drop off.
Yeah. And are there also other lifestyle triggers? Obviously, I know that the genetic factor is the main thing, but if you are somebody who is genetically predisposed to having migraines, is there anything in terms of that person's lifestyle that might be other triggers, be more likely to cause a migraine?
Yes, so the way migraine works, if you like, is you have your genetic liability to migraine, which is lifelong.
Yeah.
But then you obviously don't get migraines all the time. So there are quite a lot of trigger factors, lifestyle trigger factors, which singularly or cumulatively will make the brain more electrically irritable at a point in time and thus trigger a migraine in somebody who's genetically liable.
Okay.
There's a lot of lifestyle triggers, but there are 6 big ones that apply to pretty much everybody. And the 6 big ones are stress and anxiety, lack of sleep or poor sleep timings. There's 2 elements to sleep. Dehydration, delayed or missed meals, not eating at the same time every day, excess screen exposure, and pain and tension in the neck muscles, which is usually postural. Again, the last 2 tend to apply to office workers who are kind of sitting rigid in front of a screen for long periods of time. But, equally, if you had pain and tension in your neck muscles for other reasons, it would also.
Okay. Okay, that's really interesting. As a physio, we would often see patients who would present with a sort of cycle element to their headaches, and by working on the cervical spine and the posture, it would often have a positive influence on their headaches.
Yes, absolutely right, and it does. So the cervicogenic headache is in effect pain and tension in the muscles of the neck, triggering secondary migraine a lot of the time.
Okay, this is so interesting because it sort of has changed my perception. This short conversation has really changed my perception of migraines and headaches, and the fact that headaches are migraines, and it all kind of fits in and makes a lot more sense, actually.
Yes, and I mean, I do usually go through this kind of discussion with patients because I think it's quite important to kind of, once you understand it, as you're saying, Lisa, you get that kind of handle.
Yeah, exactly. And in terms of diagnosis or differential diagnosis, there's presumably some patients that get misdiagnosed. Is that because they've just been told they've got a headache, and actually it is a migraine, or are there other conditions as well that can mimic some of those symptoms?
So I'd kind of say misdiagnosis of migraine can kind of fall into two parts. You've got migraines where there is a prominent headache, and in that situation where the headache is prominent, it can be misdiagnosed often as other primary headache disorders. Typically cluster headache is one, or tension headaches is another one, which are other types of primary headache disorder. It can be misdiagnosed as due to causes of secondary headaches, so headaches triggered by sinusitis, although that is actually a migraine. So sinusitis can trigger secondary migraines. It's a common trigger, so it is actually a type of migraine. Those are the ones that particularly, I mean, I think kind of other headaches due to more serious causes, if that was a brain tumour, that's what most people worry about. The headache's quite different there. So it doesn't usually have quite the characteristic features of migraine, but it is obviously what people worry about. The bit that has more diagnostic difficulty is the situation where migraine does not have a prominent headache.
Okay.
So I often say to people, I redefine headache to people. I say a headache to me, as a neurologist, is anything above the level of the neck where the head is not crystal clear. So that encompasses a painful headache, but it also encompasses a feeling of brain fog, lack of clarity, fuzziness in the head. It's not painful, but it's not crystal clear. But that is still a headache to me. So you do get quite frequent, a lot of the referrals I see is where the headache is that, and it's one of the aura symptoms that is predominant. And therefore, this is the situation where things are often misdiagnosed. So a good example here is people who get somatosensory aura of migraine, where they get a tingling sensation spread down one arm or one side of the face. The headache is mild or not painful, and this gets misdiagnosed as stroke.
Okay. I mean, I guess fortunately, as a neurologist, you would be sending that patient anyway, so I guess you can then sort of unpick things a little bit more. But as you say, you know, a GP or a physio who've been sent a patient like that might completely misdiagnose it.
Yes, it does take a bit of unpicking, those kind of cases. The other one that you may come across is people who, again, the headache is not prominent and people say they feel intermittently dizzy.
Right.
And get misdiagnosed as having benign paroxysmal potential vertigo, usually. But it's about drilling down on what they mean by dizzy.
Okay.
And the dizziness is different. It's not vertigo. They describe, in migraine, it's typically more of what's called disequilibrium. You feel like you're on the deck of a ship. The world is unsteady around you, but you don't see the world moving.
Okay. Yeah, I mean, they're quite interesting and sort of different symptoms, I guess. There's quite a vast sort of difference in the types of symptoms that people can get from this. And in terms of a clear and clinical diagnosis, presumably, I mean, you as an expert, you will be able to diagnose this relatively easily within clinic with taking a history from a patient. Do you do any other tests? Do you do blood tests or MRIs or CTs, anything like that?
So you're right. Migraine is primarily a clinical diagnosis. Usually, I mean, obviously, I do a lot of it, and I'm very confident diagnosing it. So if you're seeing me, I will probably take a good history, examine you briefly, and the neurological examination of migraine is normal. And as long as the symptoms fit the migraine and the neurological examination is normal, I will make the diagnosis. I don't usually do any tests. However, I'm talking about somebody, coming as somebody who sees a lot of migraine, and I'm obviously a neurologist. And more broadly, a lot of people will end up having scans of the head because usually people are worried about brain tumours and this kind of thing, and the person they're seeing is perhaps less attuned to the nuances.
Yeah, that makes sense. And obviously, moving on a little bit to current treatments and how we can manage migraines, what are the main treatment options that are available today, and has that changed over the last decade? There must be, I imagine, some more research on this type of condition. So what are the things that patients can do or are available to them?
So I always say there's 3 planks to migraine management. The number 1 plank of always avoid the triggers. Prevention is always better than cure.
Yeah.
And if you just throw drugs at people but they don't actually deal with their poor sleep pattern or the excess glare from their monitors, they won't get that far.
Okay.
In terms of medication, there are 2 tranches. There's acute treatments for migraine. So these are medications which will terminate an individual migraine when they occur. So broadly speaking, there's 2 categories of migraine. There's episodic migraine. In other words, where I've got a crystal clear head, a migraine trigger comes along, triggers a migraine, and then that trigger goes away. And that migraine will burn out within 72 hours and you go back to crystal clear head.
Yeah.
Or you've got chronic migraine, where you've got crystal clear head, trigger comes along, triggers the migraine, and then that trigger either does not go away or other triggers come along and keep the brain electrically irritable. And this is where we get migraines extending beyond 72 hours into days, weeks, months, even years.
Gosh, yeah.
With kind of often though it's kind of a waxing and waning, more minor headache most of the time with exacerbations. So acute treatments for migraine are really for episodic migraine. And that's where they work. So these are triptans, like sumatriptan being the most common one, but there are others. And then new generation anti-CGRP drugs. If you remember that from earlier, we talked about CGRP, the chemical released from the surface of the brain.
Okay, so this medication will inhibit that.
Receptors, yes.
Yeah. Okay.
So they will both terminate the migraine very well, but only if you take it within the first 10 minutes of the migraine beginning.
Right.
And that's the bit that is often missed by GPs, is that when the electrical irritability of a migraine begins, it's quite low level. So if you take sumatriptan or you take one of the anti-CGRP oral drugs like romagepant or atogepant, 9 out of 10 times it will stop that migraine if you take it within the first 10 minutes. But beyond that point, that electrical irritability snowballs, if you like, becomes much harder to terminate. And these drugs might knock the symptoms down, but they won't terminate the migraine. So that's often missed. And I often see people who've kind of been given these drugs and they say they didn't work. And then we work out that they're not in episodic migraine, they're in chronic migraine. And of course, as soon as you're in chronic migraine, in the beginning of the migraine was a very long time ago.
Okay.
Hence those drugs won't work.
Yeah.
So the third tranche of migraine management is preventative drugs for migraine. This is for chronic migraine.
Okay.
So this is a big basket of medications. And what they all generally do is they dampen down the electrical irritability of the brain to reduce the frequency of migraines or break you out of chronic migraine. And within that, there's 2 baskets. There are what we call traditional migraine preventatives, which until 2 years ago is all we had. This is a bit of a basket of medications you'll probably be familiar with: propranolol, amitriptyline, candesine.
Yeah.
These are all drugs for other medical problems that in the era where there was no specific drugs for migraine were kind of repurposed for migraine, but they're very trial and error. So drug 1 will work for person A but not person B, and drug 2 will work for C, not D. You've got to be in a stable dose of any one of them for about 3 months before they may or may not do anything.
Well, that's so tricky, isn't it, when you're trying to manage some of these symptoms for people?
And a lot of side effects, generally. The other basket is, as we mentioned already, new generation modern anti-CGRP blocking drugs. And these are obviously very specific drugs for migraine. Came onto the market 2 years ago, kind of really big paradigm shift in migraine management once these came along, and they're really strong on migraine prevention. So if you give somebody an oral anti-CGRP medication who's in chronic migraine, that usually will break them out of chronic migraine within 6 weeks. And these are extremely well-tolerated drugs.
Oh, that's good.
They've got some rare side effects where they can cause hypersensitivity reactions of a rash or some breathing difficulty. That's about less than 1% of patients get that. In pretty much everyone else, they don't really give it, there's no common side effects. So they're very well tolerated. And there are 2 forms in a sense. There are what are called GPANTs, which are oral CGRP blocking drugs that block the receptors on the lining of the brain. And then they're bigger brothers, which are injectable monoclonal antibodies against CGRP, which actually effectively trigger your immune system to target the CGRP molecule and mop it up. And they're usually given as depot injections.
Okay, so that would be given by somebody like yourself or a GP's license to give those injections?
Not the injections. The GPs can give the oral anti-CGRP drugs in most cases. It depends a bit. These are very available privately. On the NHS, there's some restriction on their use because of their cost.
Yeah.
But the injectables are only available from specialist headache clinics, whether in the NHS or in the private sector.
Okay. So, I mean, that's a good point, actually, to just move on to in terms of some of the sort of takeaways and practical advice for patients. When is it important for them to maybe seek more urgent medical attention, I guess, both in terms of when it's a migraine, but also perhaps in terms of red flags where you might be more concerned that it's something more serious than a migraine.
I think the red flag symptoms that would make you, I suppose, seek medical attention. One of them is that the headache is strong and persistent and is not in any way getting, it's not rising and falling. It's not getting better. It's coming on and it's persistently bad. Vomiting more than once, certainly. I mean, it's not unusual in certain people to vomit in a migraine. Usually in a migraine, you vomit and people often say they feel better.
Better, okay.
But if you start vomiting more than once or you're not feeling better, that would be unusual.
Yeah.
A headache waking you from sleep. Migraines generally improve with sleep. Sleep reduces the electrical irritability of the brain. So generally, if you go to bed with a migraine, by the time you wake up, it's usually gone. If the headache actually wakes you from sleep, that would be unusual. That would give a characteristic which wouldn't be particularly consistent with a migraine headache. And of course, if you develop any new, what we would say, focal neurological deficits, so loss of vision rather than a visual distortion,
okay,
or weakness and limp arm or leg rather than just a tingling, those are kind of things which would not be consistent with.
Okay, excellent. And it would be really nice for the listeners just to get an idea of where you are, where you're based, and how they can come and see you if they are having problems with migraines.
Yes, of course. I'm very happy to help anyone who's struggling with migraines or wonders whether they've got migraine. I'm largely private now, so I spend most of my time in the private sector. I practice at the Harley Street Clinic, at London Bridge Hospital and the Shard, and also at London International Patient Services, which is a clinic in Battersea Power Station. And this is where I spend my time and see all my patients with migraine.
Great. So you're in a number of locations, and fairly easy to get to. So that's great. Well, James, thank you so much for joining us today. It's been really useful and really insightful to get some better information about migraines, and hopefully our listeners will have a better understanding of exactly what they are and how they can be treated.
Brilliant. Well, hopefully I've given that some insight into that, I hope so. Thank you for having me, Lucy.
You have, absolutely. All right, really nice to chat to you. Thanks very much, James.
Take care.
Bye.
Thank you for listening to LBSM's Ask the Expert series. We really hope you enjoyed listening. If any of the topics discussed are relevant to you or you want to find out more, please get in touch by phone, email, social media, or visit our website. Thanks again, and see you soon.